Thank you so much for joining us. Before we get started, want to send out a big thank you to the Cancer Action Coalition of Virginia and the Centers for Disease Control and Prevention who are funding this Women's Sexual Health series. These are some of the topics that we've had in the past, and we'll be going until early June with some additional topics, which you can see here. So if you saw a topic that you're interested in, you can find it on our YouTube channel, and we're hoping that you'll join us for some of the future upcoming presentations as well. Just to tell you a little bit about Nova Peterson Life with Cancer, we are a part of the Nova Shar Cancer Center located in Northern Virginia, and Life with Cancer provides education and psychosocial support to all individuals impacted by cancer, from diagnosis to survivorship, through evidence-based holistic care at no cost, no matter where treatment is received. We try to design programming that really can enhance the quality of life of those impacted by cancer, and have a lot of programming every month that ranges from support groups to fitness programming to evidence-based non-pharmacological symptom management. So feel free to check out our calendar and join us at another program in the future. We also have a specialty shop for those located in Northern Virginia. The specialty shop does carry sexual health products and also products that people may need as they're going through a cancer diagnosis. So certainly if you're on our campus in Fairfax, we welcome you to stop by and check that out. As a reminder, all questions will be answered at the end of the presentation. Please go ahead and use the Q&A feature to ask any questions that you have for the presenter. You can also use the chat feature to connect on another. We've had some really healthy discussion on the chat and some of the other series, so please feel free to do that. And then if you can rename yourself, it's helpful for us to take attendance. It can just be first name and last initial. If your name isn't showing on the screen, that would be helpful. All right. And just a reminder that this content is not a substitute medical advice. We certainly hope that people will learn a lot from this presentation and they can go and ask their provider or make decisions on their own, but that this is really education and not to be used as medical advice. So I am going to stop my share. And now I'm really delighted to introduce Dr. Rachel Rubin. She is a board-certified urologist with fellowship training in sexual medicine. She's an assistant clinical professor in urology at Georgetown University and owns her own practice in Washington, D.C., and now out in California and Los Angeles as well. Dr. Rubin provides comprehensive care to all genders. She treats issues such as pelvic pain, menopause, erectile dysfunction, and low libido. Dr. Rubin is the director at large and former education chair for the International Society for the Study of Women's Sexual Health and an associate editor for the Journal of Sexual Medicine Reviews. Her work has been featured in the New York Times, NPR, and PBS. She was named a top doctor in Washington from 2019 to 2024. She really is one of the leading experts in sexual health. She has great content on Instagram and other social platforms, and really is just a wealth of information, especially for people who've been impacted by cancer. So we're so delighted to be able to learn from her tonight and have her here. And I will pass it over to you, Dr. Rubin.
Oh my gosh, what an honor. It's such a great honor to be here. We've done this a couple times now. I think we've done it for the men as well. And it was always a big hit. And I've always loved talking to this group. So I need a little lively chat box here because I don't want to talk to just nobody. What brought you to this lecture? What do you want to hear about? What do you want to learn about? Why does this interest you? Where are you finding struggles? Or are you just curious and interested to hear what other people want to know? I want to see something in the chat box that makes me know I am not just talking to the ether, because we can really tailor this and make this fun and interesting. So let's see if anybody answers. Do they have texting ability? It makes me wonder if they have texting ability. Sometimes there's like a setting that you can,
Yep, we have some coming in.
Oh, there we go. Okay. We've
Okay,
got
good.
people who have sudden menopause by chemo, people with pelvic pain with radiation, nervous about starting tamoxifen and how's it going to affect my libido? Oh my gosh, I love these. I love these answers. Let's see if anybody else writes in. Be brave, people. Be brave. I'm going to share my screen while I'm waiting for you to talk to me. All right, I'm going to share my screen. Taking testosterone cream for low libido. How fabulous and wonderful. Um, Body image issues. Feeling body, things are not working yet. So I want to keep this pretty broad in that everybody, I assume, has different medical histories, different biology, different social situations. Um, Gosh, someone's feeling nervous about her libido because it's normal, even though she is on all the things. And so, wow, so the opposite. Is my endocrine therapy worsening? Gosh, that I feel for you on that one. I'm so happy. You know, this is the woman, right? Because you're damned if you do and you're damned if you don't, right? If you don't have side effects, you're worried that the cancer is going to spread. If you do have side effects, you worry what happens to your sexual health and your quality of life. And so I feel for you. Yeah, I really, it's a tough one. So what I want to talk about today really is just some biology because there's so much biology. You know, it seems obvious that that biology is affecting cancer greatly, but it's also the psychosocial impacts, what it does to you and how you feel about yourself, what it does to your partner and how your partner touches you and feels comfortable, you know, touching you and wants to want you. And sometimes you want to be wanted, but you don't always feel the same way that you did before. And the gas tank is feeling kind of empty. And so the challenges that we have, and it's so funny because you've had such amazing speakers. I'm so amazed and happy and thrilled and delighted that I'm not the only person yelling and screaming about this stuff. You've had people, lots of people talk that I know and really adore. And I think it's really amazing that Inova is doing this group in general, because there's so much need for all these resources and to know not only are you not alone, but there are many people out there who want to help with these sort of different problems. I think it's a challenge because sex is always so private, right? We can't talk about it. These are my private parts. I should be lucky that the cancer is being treated. I shouldn't have, like, I shouldn't, it's greedy to want to have a good sex life. It's greedy to want to have my orgasm and cake too, right? It feels wrong. And also, your doctors aren't really trained to talk about private parts, even your breast oncologist or your gynecologic oncologist or your regular gynecologist or your primary care doctor. They really don't get training much at all about how to talk about sex. And the funny thing is the more I learn about this and the more I talk to people, the more I realize that you can never assume what kind of sex your patients are having or what kind of sex they want. I've stopped assuming. I've just started asking questions and being curious and really trying to. My New Year's resolution has been to meet people where they are and give them what they need. Meet people where they are and give them what they need. And so I also try to do it with a little bit of a smile because, and I want you to read that cartoon there, because if you can't, sex is supposed to be fun. It's supposed to be joyful. It's supposed to be silly and awkward and really joyful. And if it hurts and if it's dry and if you don't want it and if it's not fun, why would you want to do that? Why is that something that you would want? Um, and your doctors, right? Why is this the way that we look at you, right? We look at you like under a sheet, like we're mechanics looking under the hood, right? We're hiding your own body from you. And the challenge is that your genitals change a lot. Forget cancer. Your genitals change a lot with any kind of hormone changes. And cancer obviously can speed up hormone changes or worsen hormone changes. But the health of the genitals change quite a lot. And this isn't just a little vaginal dryness. This isn't just a little irritation. This is pain. This is pain with sitting, pain with wearing pants. This is also urinary problems, urinary frequency, urinary urgency, urinary leakage. And the challenges of the hormone changes of the genitals can cause recurrent urinary tract infections, which can and do kill many women every year. And we think about urinary tract infections, we minimize them, but they actually cost our healthcare system a lot of money and they kill people and we minimize it. And so really I want the more we can understand our biology and understand sort of what goes into, really good sex, then the better we can advocate for ourselves and that you can go to your oncologist and confidently ask him about sexual health and not be frustrated when they look at you like deer in headlights because you deserve that. You deserve great sex all the time, right? And you deserve to understand the toolbox and what lives in the toolbox. But we have to care about all of you. We have to care about your hormones and your tissue health and your body image. And we have to care about your relationships and communication. And are you safe? Are you safe in your house? Are you safe in your body? Are you safe? How is your mental health? How is the trauma with all of this? And we have to look at you sort of in a biopsychosocial approach. So that means you have to have enough time and you have to pick clinicians that really get to know you because how can they meet you where you are and give you what you need and understand who you are and where you come from and your past experiences and your religion and your sort of what you want? How on earth do they do that in a 10-minute visit? And why is it only your cancer doctor who gets to spend more than 10 minutes with you? It's your cancer doctor and your therapist. Why they are the ones who get to spend more than 10 minutes with you. This is the problem in medicine. You have to have cancer mental problems for anyone to want to spend more than 10 minutes with you. And that is a crime, in my opinion. That is an absolute crime. And so what do we do? What do? I joke, I'm kind of like the sex detective. Like the reason I love what I do is because I get complex issues. So I get to take people and I get to try to figure out how can we optimize their life? How can we improve upon you living, right? Someone in the chat here says, my oncologist was surprised I still wanted to engage in sex after pelvic radiation. Oh, women in their early 50s want sex? Clutch my pearls. Oh my God, right? That is unfortunately the reality that we live in. Of course, you still want that part of your body. Of course, it's important to you. And if it's important to you, it should be important to your radiation oncologist. And we have to have these questions. Now, I have a friend who's a radiation oncologist in New York City at Mount Sinai. And she's the first person to ever get NIH funding to look at the clitoris under MRI guidance when you're talking about radiation oncology. There is not even a footnote in any papers of any textbooks of anything that has to do with radiation oncology that has to do with the clitoris. Not one thing. I can't say the same for the penis, right? We study the penis all the time in every place, in every possible crevice and corner, and yet it's never been studied in radiation oncology. And that's what we're dealing with in 2025. So when you go to your doctor saying, and they look at you surprised, it's because no one ever taught them. They don't have a book chapter. They don't have pictures in their textbooks. They truly don't get it. And they were never trained in thinking about sexual health issues. They just trying to keep you alive. They are not really concerned about keeping you living unless we force it upon them, which is what we're trying to do, is find people that it shouldn't just be a cancer doctor that you go see. You should have other clinicians in your life that are helping you. Now, a sexual medicine clinician looks a lot of different ways. It could be a primary care doctor or a urologist or a gynecologist or someone who, it could be many different people who have interest in sexual health. We love, and I'll tell you how to find people like that, but we love pelvic floor physical therapists. I know you spoke to one, which is so wonderful. We love sex therapists. We love mental health professionals. They're so amazing and absolutely excellent. ISWSH, which is isswsh.org, the Women's Sexual Health Society, is a great place to find a doctor who cares about these kinds of issues. That doesn't mean they know everything, but it means that they care enough to be on this website. And then we have menopause doctors that you can find through the Menopause Society website that also has fine providers of people where you can have nuanced conversations about hormones and cancer because it is not a one size fits all. And your body deserves a nuanced conversation. In fact, I had a long conversation today with a patient who's 65 and had breast cancer that was hormone receptor negative. And she's really worried about her osteoporosis, and she's worried about her brain, and she's worried about, and everyone's talking about hormone therapy. And so we had a long, nuanced conversation about the pros and cons and what we know, what we don't know, the risks and benefits. And she's going to make some educated decisions of what she wants to do with her body. And everybody deserves that. I want everybody to know the toolbox and to know that you are not just your cancer, but you're a whole person who deserves whole person care. Now, whole person care often comes with rehab and physical therapy. This is pelvicguru.com. There's lots of ways to find a pelvic floor physical therapist. This is just one of them. But it's important that you know if you've had surgery, if you've had radiation, if you've had chemotherapy, if you've had anything, that your muscles and joints and your bones are affected. And so getting strong and doing rehab is really necessary. And we don't do enough of that. We don't spend enough time doing that. And then, of course, mental health. You all know that how important mental health is to these kinds of issues. So, one of the things that I do, one of the approaches that I take with patients is I just ask them. I ask them about their sexual health. I ask them about their arousal, about their orgasm, about pain. I ask them about their desire, their interest level. I ask them about their medical history. I ask about surgical history. I ask about what you care about, what your goals are. I ask about trauma and if there's anything that I need to know more about you, about your culture, about your religion. And I think about patients when they tell me their stories, I think long and hard. I'm always thinking about this. I'm thinking about this idea that sexual dysfunction can come from anywhere, right? Your brain and medicines that work on your brain. It's your spinal cord, because if you've got back problems, you can have pelvis problems because those are the nerves from your back. And I think all the time about the genitals themselves and all of the things that can go wrong when you play with cancer and hormones and chemotherapy and surgeries. So many things can go wrong. And so you deserve to have expertise, people who are experts in understanding, what could we do to improve the quality of your life? And the challenge is we have to fight for more data, because we don't have studies that show danger for many of these things. And so patients become nervous and fearful of things that are not factually based. Like, there is no data on earth to show mortality from breast cancer using vaginal hormones to treat the genital and urinary symptoms that happen. Not a single paper to show mortality. And yet, patients are afraid to take vaginal hormones, and oncologists are fearful in prescribing it because they're called hormones and it's microdosing, estrogen or DHEA, and it can save your life from a urinary tract infection. And there's no data to show worsening cancer. And so the question becomes, do we not take something because we're afraid of it, even though there's not a study on earth that shows harm and lots of studies that show benefit and actually less death? But unfortunately, we choose fear a lot of the times. And fear can lead to some significant consequences. So it sounds like you guys spoke to Lori Brotto about libido. She is one of the, it's absolutely incredible that you got Lori Brotto to come speak. She's a very famous psychologist in Canada who talks all about libido and mindfulness in sex, right? If every time your partner touches you in a place you had cancer, or you think to yourself, I don't like my body, or I'm not happy with how I look, or, I had cancer, that's not sexy. So how do we get your brain thinking mindful thoughts of like pleasure and intimacy? Because you deserve those things. You deserve pleasure and intimacy. But also, if you're it's kind of funny. I use a lot of car analogies, and I don't like cars very much. I'm not a car person. And yet I find car analogies are very helpful. This idea of like, if your car has no gas in it, it doesn't matter how much you press the pedals, you're not going anywhere. And so when it comes to libido and desire, right, there's a lot of biology that goes into getting your car to drive. And so there's dopamine, there's testosterone, there's estrogen, there's melanocortins, which many of you have never heard of. And there's also like things that hurt your libido, like chemotherapy or antidepressants and things like that. So when our libidos are empty, it's not, honey, I don't find you attractive anymore. Honey, of course I find you attractive, but my gas tank is empty. right? And how do you talk about that with your partner who knows you one way if you have a partner, or how do you find a new partner if your gas tank is empty? And so understanding the biology that goes into this of like, what if you were to add gas back into your tank? And we do have hormonal and non-hormonal medications that can do this. But the answer is if it feels good, like if you want gas in your tank, you deserve gas in your tank, right? You deserve it. You deserve a shared decision-making, evidence-based discussion about what it would mean to put gas in your tank. And I was telling someone today, I said, well, if you get an old car and it has no gas in it, it can sit in your driveway and it's still a car, right? It's still a car, but it's not going anywhere. And you can press all the pedals you want and it's not going anywhere. And it's going to gain some rust and it's going to get a little creaky and it's going to lose all the fluid in it. It's not going to be able to work very well. So again, when you add things to the car, when you put gas in it, when you get brake fluid in it, when you get it tanked up, it can move places. It can go as fast as you want. And so I love that analogy for menopause because I think it's super helpful in this idea of like what it feels like when you have gas in the tank and fluid in the brakes and when you don't. And it doesn't mean you're not worthy. Like you can live a life without those things and you can live a full life without those things. But are there ways to boost sexual health by pulling some different levers to help boost some of the biology? Because it is not all psychosocial, okay? It is what we call biopsychosocial. It's all of it. So arousal, and I promise I'm going to speed up because I do want to just have a discussion and answer some questions here because it truly is trying to meet you all where you are and give you what you need. And that's, as I said, my New Year's resolution. But arousal and orgasm, we don't really spend a lot of time talking to women about. Think to yourselves, have you ever been asked by a medical professional if you could have an orgasm? You can answer in the chat. You don't have to. But have you ever been asked if you can have an orgasm? Not once, not once. No, as people are saying. Nope, I haven't, right? Everyone knows what I do for a living because I'm usually wearing a vulva or clitoris on my necklace, but I don't have it on today. But I've never been asked by a doctor if I can have an orgasm. So I certainly have never been asked, how do you orgasm? What brings you to orgasm? Is it penetration, which is very rare? Is it clitoral stimulation, which is the most common? Is it nipple stimulation? Do you orgasm in your sleep? Can you have coregasms when you do core exercises like some people can? We don't ask those questions. So when someone is going to do a mastectomy or a lumpectomy or radiation or chemotherapy, when someone is going to take out your pelvic organs, when someone's going to recommend putting mesh to help with prolapse, if they don't know how you experience pleasure, how can they properly counsel you on the way these medications or surgeries will affect your body? I had one patient come to see me once and she said, Dr. Rubin, when I orgasm, I could taste color. And then I had a baby and I lost my ability to taste color. And she was real mad. And I understand why she was mad because if I could taste color when I orgasmed, I also would want to maintain that and protect it with my life. Now, she had a watermelon baby come out of her pelvic floor and she lost her ability to orgasm in that way. And so, but knowledge, I believe in informed consent in that if we understood our bodies better, if we had better conversations with our clinicians, that they understood how we experience things and they understood how their surgeries affect things and their medications affect things, we can have more nuanced conversations about what are things I'm willing to do and what are things I'm willing to not do. And we do this a little bit better, not great, still bad. We do this a little bit better with men. Men who have prostate cancer, right? We have these conversations about erectile dysfunction, about changes with orgasm, about libido, about all of those things when they have prostate cancer and things. And there's a little bit more shared decision making. We actually watch a lot more prostate cancer than we used to because of this worry about the risks of all the sexual side effects of the treatments for prostate cancer. We do not have these conversations with women. It is a disaster. We should be having these conversations. Yes, everything changes as your body changes. You get hysterectomy, menopause, hormones. And often I find that people don't know how their bodies work. They don't understand all the nerves and how all these nerves affect your sexual health, affect your clitoris, how it all affects pleasure And if we don't know how you experience pleasure, how can we know if our treatments are going to screw up your pleasure? And does that matter to you? Because some people it doesn't matter to, but if it's y'all showed up to this webinar, which I think means maybe it matters to you. Tell me, does it matter to you? Does sexual health and quality of life matter to you? I don't care if it matters to your partner, but does it matter to you? At least a couple of you say yes, yes. Oh, I got more yeses. Very much. It matters to both of us. Yes, absolutely. And it should. And it's okay that it does. And you don't have to apologize. You should never have to apologize for that. I love that you're all here. I just love it so much. I love that you're advocating for yourselves, that you're showing up in a big way. So you see this picture here. It's you see the man on top of all those bills and the woman just trying to get up there with all the coins. Have you guys heard of the pay gap? Yeah. Have you heard of the pay gap that women are paid less than men? Well, yeah, I had to start my own medical practice because there was no way I was going to get paid anywhere near what a urologist gets paid if I do sexual health care. So I had to start my own practice. So there's a big pay gap in our country. Have y'all ever heard of the orgasm gap? Tell me. All right, one of you has not heard of the orgasm gap. Yes? No? Okay. So not only do we have a pay gap, but we actually have an orgasm gap in this country. So what I mean by that is if you ask people at your last sexual encounter, did you have an orgasm? Heterosexual men say yes, 95% of the time they had an orgasm. Heterosexual women, it's 65% of the time. So 95% of the heterosexual men say yes, and 65% of the heterosexual women say yes. Women do not orgasm to the same percentage that men do. Why? Why do you think? Why do you think women don't orgasm as much as men in heterosexual couples? It's a little better when you get to bisexual and same-sex couples. Why do you think that is? It's because of biology and physiology, how the body works, okay? Because, well, yeah, some women fake it, that's for sure. It's because they don't know their own biology, because they think that penetration is the pathway to pleasure, right? They think, because that's what is in the movies and that's what's in the porn and that's what everybody sort of thinks, that penetration gets you to orgasm. But we know that the penis and the clitoris are exactly the same thing. In fact, I'll show you a picture here. The penis and the clitoris are exactly the same thing. It's made up of the same cells, the same tissue. It's 100%. I'll show you another picture. We all start the same way, and the penis and the clitoris are exactly from the same biology. Okay, if you slice them open, they look the same under the microscope. It's just that the clitoris is more buried. It's underneath the surface of the skin, and you can only see the tip of the head of the iceberg, like the tip of the head of the penis. And so how do men orgasm, right? Penis. Penis is how men orgasm. It is through stimulation of the penis that the majority of men orgasm, okay? So if the penis and the clitoris are the same thing, what is the pathway to most female orgasms? What do you think? Let's see if anyone answers. So if you stimulate the penis, yes, the clitoris, right? The clitoris is not the vagina. In fact, the vagina's down here, the hole to the vagina's down here, the hole to the vagina is here. It's kind of far away from the head of the clitoris, and the legs of the clitoris are buried deep inside the labia majora out here. Okay? So how on earth is penetration going to get women to orgasm? It's not. And that's why less than 15% of women orgasm with penetration, right? It's not normal to orgasm with penetration. If you are someone who could or used to orgasm with penetration, you are a ninja unicorn and you had a special superpower and maybe still have a special superpower, but it is not normal. Never was, never will be. Okay? I have a theory behind it, which I can share with you if you're interested. But men, yes, you're a unicorn. Congratulations. We're all jealous of you. Men do not orgasm when they rub their inner thigh. If a man rubs his inner thigh here over and over and over again for an hour, for 2 hours, for 5 hours, right? He could rub it all day long and he will not orgasm. So for many women, if you penetrate the vagina over and over and over again for longer, for shorter, for harder, for slower, you still won't orgasm. You still won't orgasm. Why? Because it's not your clitoris. Just like the thigh is not the penis, the vagina is not the clitoris. It seems logical. It makes sense. So my theory, okay, someone asked for my theory. You all know that there's a certain percentage of men who have premature ejaculation, where men are stimulated and orgasm very quickly in like a minute or less for some of them. We're not very good at treating it, but the idea is their nerves are different than people who can, go longer before they orgasm. So if all penises and clitorises are the same and come from the same nerves and the same body parts, well, then that means that there's a percentage of women who have premature ejaculation. They orgasm easily. Their nerves are more sensitive. Those are your unicorns. The women who can orgasm from penetration, it is the lightest touch to the clitoris, the littlest bit of sensation that boom can get them to orgasm. It's the same thing. In men, they run to the doctor because they're so upset and mortified by their problem. In women, everyone thinks that's the norm and that's what should happen. Right? Does that make sense? Is that interesting to you? What do you think of my theory? Let's see. Yeah, for some people, it's way too sensitive. Super interesting, right? I have to prove it with science. I really want to. I have a big research team. I'm going to try to figure out how to prove it. But it's logic. You take what you know about one part of the male body, and you use the logic to say, what is the equivalent in the female? Because it's the same biology, it's the same anatomy, it's the same nerve structures, it is the same. So if you have 10% of men who have premature ejaculation, you have 10% of women who have premature ejaculation. What does premature ejaculation look like in a woman? Boom, she orgasms quickly, which means those are ninja unicorns who are orgasming so easily, and everyone thinks that they should be them and they should be normal. I don't see men wishing they had premature ejaculation, by the way. Kind of makes you think, right? Let's go back to the pay gap, right? You with me? That women are paid less than men, which is why I had to start my own medical practice, right? So if I give we have a pop quiz we're going to do with you guys. You're so interactive. Thank you so much for being interactive. It literally is the greatest thing. What a great, wonderful group you are. Absolutely incredible. If I give a stopwatch to every heterosexual man on the planet, and he enters a vagina and he starts his stopwatch and then he orgasms and ejaculates and then he stops his stopwatch, how much time on average goes by? Give me a guess. How much time on average goes by? What is average amount of time? We've got 2 minutes, 7 minutes, 20 seconds, 3 minutes, 2 minutes, 3 minutes. I love that you're 5 minutes. All right, we've five, yeah, we got some winners here. So the answer is about 5.5 minutes, okay? And 5.5 minutes is average, which means half are way above it and half are below it. Now in America, it's about 7 minutes, so 2 of you are right. USA, we're great, right? 7 minutes versus 5.5 minutes in the world. It is wild that we do have that data, by the way. So 5.5 minutes. Now it's interesting because if you give the stopwatch, so let's play that game with the opposite partner. You get a heterosexual couples and you give the woman the stopwatch. Penis enters vagina. How much time has to go by for the woman to have an orgasm? We've got a guess of 20 to 30 minutes. Infinity, 30 minutes. I love your brains. You guys have such smart brains. 20 minutes, 15 minutes. All right, so this study was done. It was really hilariously small numbers and a silly study, but it was 13.5 minutes. 17% never had an orgasm, which is true. 20% of people have orgasm problems. So that goes in line with that. 17% have never orgasm. And read it with me. Penovaginal intercourse was insufficient to reach orgasm in the majority. Right? Yeah. So someone said it depends on how much clitoral stimulation. It depends on what's being done. Now, this is so funny because I guess it was a worldwide study that they asked people. And so in the Czech Republic, you can orgasm in 6.8 minutes, but in Hungary, it takes 22 minutes. So it just shows you that next time you guys go to Europe, I want you to try this to see if it changes how long it takes you to orgasm, based on where you are in your European vacation here. Here, where was the United States? It was about 13 minutes. Now, what's so interesting about this data, right, is that many people never orgasm, and penetration is not the path to orgasm. But even if we take this to say with penetration, it's still 13.5 minutes. So where on earth in this 5.5 minute game are you guys going to have your orgasm? Does that make sense? Like how is it going to happen? Like the math isn't mathing here. So how do we reach orgasm equality? How do we fix that orgasm gap? And I believe truly that if we fix the orgasm gap, the pay gap gets better because women show up differently. If they actually valued their own orgasm the way men value their orgasms, women would show up differently in the workplace. I truly believe that. So it's really, kind of interesting because women say, well, he's only going to last 5.5 minutes and it takes me 20 minutes to have an orgasm and I need a device or I need hands or I need this. You know what? I can just do it on my own. And on my own is kind of a common thing because if you give women their own tools, their hands or a vibrator, they can also orgasm about 5.5 minutes for the most part. And often they don't need penetration because penetration is not the path to orgasm. And so you had an amazing speaker, Teal Dye, who owns Lotus Blooms, which is so cool. It's a device store or sort of a store that sells all sorts of devices. But this idea is, as a doctor, should we be normalizing devices for couples? Things that vibrate, things that feel good, things that stimulate the clitoris? And my answer is yes, we absolutely should be. And we have data to support that. But this idea of, well, where do you put it? You put it outside the labia majora because underneath is where your clitoris is. You put it up here. And if direct clitoral stimulation is too sensitive, you put it around the area. And this makes your relationship and your sex life better, not worse. And that's where we have to convince your partners, because it's not because they're not good partners. It's because their penis is not the pathway to your pleasure. It is clitoral stimulation. Just like you can rub their thigh all day long and you're just not going to hit the spot. You're just not going to hit the spot. He's going to say a little to the left, right? And so how do you get comfortable with a partner in saying, hey, honey, what you used to do used to be good and great and fine and work, but since my chemotherapy, it's not working anymore. We need to get some help. We need to get some aids, some tools, some things that make it better. Adding lubricants, adding moisturizers, adding vibration, adding things that help. And if you have pain, adding things that actually fix the pain and not just mask the pain. And so if you're in pain, it is so hard to have good sex. Gosh, it's so hard to have good sex, but you deserve to understand your pain. You deserve to have education around your pain and to really know the real risks, benefits. So I want all of you to follow me on social media, especially Instagram, not because I want more followers, although it's so fun. But it's not because I want more followers. And that's my handle up there. It's Dr. Rachel Rubin. I want you to follow me because I am always sending data out there to convince you that vaginal hormones are safe no matter what. If you've had cancer, the data shows they're safe. I have data to show you that if you use vaginal estrogen and you've had breast cancer, you have less chance of a risk of dying. Truly, that data exists. You have less of a chance of risk of dying. And yet everyone's so afraid. But the genitals, the vulva is very hormone sensitive. So if you've had your ovaries out, if you had chemotherapy-induced menopause, if you have menopause, if you're on breast cancer therapies, the opening to the vulva, this tissue here that looks like a sunburn that's red, raw, and irritated, it hurts. And actually that's bladder tissue. So it's skin, bladder tissue, and then inside's vaginal tissue. So when this tissue is raw and irritated, like a plant needing water, or if we go back to the car, if like the brakes needing fluid, if they're empty, they're irritated, they're inflamed, they're uncomfortable, and it hurts to the touch like a sunburn. And that's not just pain with sex, although it will be painful, but it's also urinary urgency, frequency, leakage. And the thing that kills you is urinary tract infection. And this is very serious. And this is a topic that I am so passionate about. I have passion coming out my ears. And it's this idea of genitourinary syndrome of menopause, which means if you are in menopause or chemo or surgical induced menopause, or you're breastfeeding, or there's lots of birth control pills can do this too, but you have symptoms, you get dryness, decreased lubrication, pain with sex, thinning of the tissue, but you can have changes to your orgasm, to your arousal. You can have irritation, burning, and itching. You can get dysuria or pain with urination. You can get urinary frequency and urgency. And the thing, because of this dysbiosis or this change in pH, normally the tissue should be acidic, but it becomes less acidic and you can't fight infection. So the bad bacteria grow. And so you actually can look at with your eyeballs and see changes. You can see the labia minora shrivel up and disappear. You guys, I've gone so viral on TikTok talking about this, and I'm not on TikTok, but like celebrities and my elementary school have all seen me talking about labia minora shriveling up in menopause, and it has had millions of views on the internet. It's the funniest thing that's ever happened to me. But legitimately, you have no labia, like very small labia minora when you're a baby. You grow them in puberty and you lose them in menopause, and no one scientifically has researched this. It's hormone sensitive tissue. You can see paleness and irritation. You lose the stretchiness, the wrinkliness of the vagina, and you can get urinary tract infections, which can kill you. Truly, truly can kill you. So, when we're trying to save your life with cancer, why let you die of a urinary tract infection? It doesn't make sense. We have to have these risk benefit discussions. And unfortunately, we just published guidelines. So, if you do follow me on social media, all of my content right now is about this topic because all of my content is about this topic because we just put out guidelines with the American Urologic Association, which says that there is that vaginal hormones, vaginal estrogen, vaginal DHEA are safe to treat all of these symptoms. They treat all these symptoms, they prevent all these problems, and there is no evidence linking it to developing breast cancer or worsening breast cancer, and that you deserve these shared decision conversations with your doctors. And I'm hoping, because a big association did these guidelines, that the oncologists will have to listen. And they do, they have their own guidelines that are supportive of this, but the general oncologists in the community are not offering women this. They're not doing this, or they're saying that I don't do this. And so, what does it look like? It could look like a tiny tablet of estrogen that is microdosing. It is like 100 times less the dose, actually a million times less the dose than a birth control pill. It is a microdose. It's like putting hydrocortisone cream on your bug bite versus taking IV steroids in the hospital. Very different things. So if you microdose this tiny minuscule dose of estrogen in the vagina twice a week, you can prevent UTIs by more than half. More than half. And people die of urinary tract infections. I know I keep saying it, but I truly, truly mean it. And so often, once you fix the painful tissue, then the muscles are still tight. Genetic cancers at no effect. If you have a genetic cancer, you should be offered, because again, if you have a genetic cancer, you can still die of a urinary tract infection. And there is no data on earth to show mortality from, if you have an ER/PR positive cancer. Oral DHEA, there's no data, and oral DHEA does not fix this problem. Vaginal DHEA fixes this problem, and there's a product called Intrarosa. And so this is where there is the absence of any evidence to show mortality from cancer when you use these vaginal hormones, but there's lots of data to show a mortality benefit because you're reducing the risk of urinary tract infections. So it's really important that you understand that you are not just your cancer, but that by causing all of the harm of menopause, it can increase your risk of dying of other things, fractures, urinary tract infections, other things. So we have to have these risk benefit. So dyspareunia, great question, is painful sex. So pain with penetration. And so if you have any of these symptoms, you don't like wearing clothing, you have pain with sex, or near frequency, urgency, often it's not just a hormone problem, which it is, and we fix the hormonal piece, but then the muscles underneath are still tight. So it's like putting your hand on a hot stove, your muscles tighten up. And so you got to turn the stove off, but you also have to get the muscles to relax. So we do a lot of sort of puzzle work where we take this biopsychosocial approach where we care about your mental health, your hormonal health, your musculoskeletal health, and we really try to work with you because each one of you have different problems, different things that are wrong with you. And you deserve a nuanced conversation and advocacy around it. Anyway, I'm so thrilled. I'm going to stop talking and answer some of these questions. But was this helpful? Did you learn something? Was this helpful at all? Yes. Oh, good. At least one person liked it. We have a newsletter. If you go to rachelrubinmd.com, I have a newsletter, and I promise I don't spam. My passion, I am passionate about research, advocacy, and education. And so my newsletter, which we send out a little less than once a week, but it's all on just what's the latest data, what's the latest research. Because the challenge is your doctor doesn't always know. And when you see something that's helpful, you can then bring it to your clinician and say, hey, like, what do you think of this new paper? And they're going to say, well, I haven't seen it. It just came out. And you're going to be like, I know, I knew it before you because I'm on top of this stuff. And if they tell you that they're interested and they want to review it, they're a good doctor or clinician, keep them around. If they tell you to stop going on Google, you kick them to the curb and say, I need a doctor who cares about me. So doctors are not robots. We are not Chat GPT. We do not know everything. Your cancer doctor can barely keep up with the cancer studies. They don't know about menopause. They don't know about hormones. They don't know about the genitourinary syndrome of menopause. And so that's why I fought so hard for these guidelines, because then you can show up to your doctor, yes, with an Instagram video of me talking about it, but in the other hand, you can have a guideline that says this was put out by the American Urologic Association. This is evidence-based research and medicine, and this is the up-to-date guidelines. What do you make of this? Does that make sense? Is that helpful? I'm going to share the guidelines with you. Oh my goodness, my children just came home, so I got to shut the door so you don't hear them. They're very noisy. 1 second. I'm going to give you these guidelines in the chat. And then 1 second. Hi, family. I'll be done in a minute. No, not yet. Sorry about that. I've got an 8-year-old and a 6-year-old. They just came home from soccer practice. All right, so let's get questions going. So people thought this was helpful. That's good. And again, it matters. If this matters to you, which it should, and it does because you're here and you are all said it matters to you, then that means you need a team around you. And I think of it, I'm going to do one more car analogy, and then you can tell me to shut up with car analogies. But it's like a pit crew. There is not one doctor that is in charge of you, that owns you, that tells you what to do. You're the boss, you're the car. And you need a pit crew. That means you need someone helping with your mental health. You need someone helping with your musculoskeletal health. You need somebody helping you with your cancer. That's just one member of your pit crew. You may need someone helping you with your sexual health. You may need someone, and when the pit crew member is not serving you, is making you feel less good than more good, then sometimes you got to switch people out. Okay. And you have to be the car that is in full control over how you do car maintenance. And the other, okay, fine, one more car analogy. The other idea, now that you have had cancer, you are no longer a Honda Accord. Sorry, you're not a Honda Accord. You cannot go to the Honda dealership. You are all Lamborghinis. Okay? You're not broken. You're not a clunker. You're not broken. You are fine, fancy sports cars that need fine tune-ups. Okay? You do. You need fine tune-ups, which means sometimes you got to spend a little money. Sometimes you got to travel. Sometimes you got to wait for the part to come in. But you have to add, and you cannot park in the same garage that everybody else parks in, and you got to get one of those fancy covers. You are a Lamborghini, and you got to live your life with the energy of someone who is a Lamborghini and deserves to be that fine sports car. So truly, I hope that helps, that those car analogies. My goodness, I didn't realize I had so many. All right, so let's see, Q&A. There's some Q&A. Pain with sex. So pain with sex is 3 things: hormones, very often hormones, and vaginal hormones in those guidelines that I just sent you, and you're going to follow me on social media. Vaginal hormones, there is nobody who cannot take vaginal hormones. There's no data to show that it will kill you. There's no data to show that it's going to kill you. And so you deserve to have a nuanced conversation and understand there's fear. I understand the word fear, but there's facts too. And so we have to talk about vaginal hormones. There's moisturizers and lubricants, which can help bring the pain down a little bit, but not always fix it. It doesn't fix the problem. The vaginal hormones fix the problem. The vaginal moisturizers and lubricants help with the symptoms of the problem, and they've never been shown to prevent UTIs, urinary tract infections. So vaginal hormones is the first thing that's the reason of pain with sex. The muscles, the pelvic floor muscles being tight, is the second reason for pain with sex, and those go together. The hormone problem then causes the muscle problem. Again, putting your hand on a hot stove, your muscles pull away. The answer is not fix your muscles, it's turn off the stove and then fix the muscles. And then the third problem is nerve issues. So sometimes nerve problems can, so if you've got a nerve issue, which could be a back issue or a back problem, that can cause pelvic pain too. If you got a hip issue, right, that can cause pelvic pain. So understanding your nerves, your muscles, and your hormones are very important. And sometimes that's three pit crew members to kind of look at all of those things as in a holistic, like whole process. Um, so, if a UTI has such a crossover between side effects of cancer treatments and menopause, how do you tell what is what? So, if you are menopausal, right, then hormones is the most obvious reasons why you're getting UTIs. Now, if you're immunocompromised because you're on cancer therapies as well, even more of a reason to consider vaginal hormones to support healthy tissue. Okay, I'm going to use an analogy that's not a car. Think of a plant that needs water. Okay. If your plant doesn't have water, it's going to shrivel up, it's going to crack, it's going to die potentially. But if you put a little bit of water in it, it'll perk it right back up. And so the vaginal hormones help to keep the plant as strong as possible while then it goes through other snow and ice and other sort of different treatments, if that makes sense. So definitely consider vaginal hormones because it works. It works extremely well. It takes about 2 to 3 months to start working, and it only works if you keep doing it. But it could make it so that you can make it through a movie without peeing. It could make it so you can have sex with your partner if you want to. It really can make the quality of your life that much better. And the data on risk is just not there. It just is not there. I did see a study that the use of vaginal estrogen is under scrutiny of women's on AI. So there's 2 papers that look at potential recurrence with AIs. There's a lot of paper and large meta-analyses that show no risks of recurrence and progression or mortality. So there's a lot of data that shows no risk. There are 2 papers that do show a very small blip and no increase in mortality. Those papers were before 2 things, before HER2/neu. Okay, so before we had good treatments for HER2/neu, and these patients were at higher risk in general. And number 2, they used much higher doses of vaginal estrogen than we have today, which means we are still microdosing these vaginal hormones. So, and I always say to that, okay, we have 2 small studies that were crappily done that were before the HER2/neu and with higher doses of vaginal estrogen. And tamoxifen causes uterine cancer. I'm going to say it. Tamoxifen causes uterine cancer. No one doesn't take tamoxifen because they're afraid of uterine cancer. And yet it causes cancer. And yet we still gladly tell people to use tamoxifen. And so to tell people not to use vaginal estrogen for a fear of 2 crappy studies when the overwhelming evidence of all other literature, there's not a single paper that shows mortality and no other paper that shows problems with recurrence, but a lot of papers that show no increased risk of recurrence. How can we be afraid of something that shows mortality benefit? Like there are papers that show mortality benefit. So that's where I stand on it. And that's what means that you deserve a nuanced conversation because it is not black and white here. I understand the fear and I understand why people are afraid, but it's facts. Like what are the facts and what is the fear? For vaginal hormones, what are some names to ask for okay, I got a good I'm gonna take you through I've got on my website, I'm gonna pull it up. I have education. Let me see if this works. Okay, hold on. Let's see if this works. I'm going to share my screen. Share my screen. All right. If you go to rachelrubinmd.com and you go to more and you hit on education, okay, it says prescriber's pocket guide. If you put your email in and you hit sign up, you can download what is a pocket guide, which has what is GSM? We have a YouTube channel that answers lots of questions about GSM. And these are the prescriptions and teaches your doctor how to prescribe the medicine. So you could download this and send it to your doctor. And these are kind of the tools that we have in our toolbox. And on our YouTube channel, we have lots of videos of all of us talking about this many, many times over, even webinars. We're doing a webinar tomorrow night for doctors to teach them how to prescribe these medicines. So let me click the link here. Let me see if I can click the link here. I can put it in here. So we are trying to think of every way. Now, here's a really important thing. When you have vaginal estrogen, there's on the box. The box says of the product says that it causes stroke, blood clots, heart attacks, probable dementia, and cancer. And 0% of that is true. In fact, there's no studies to show any of those things, not a single study. Why does the box say that? Because in 2003, the FDA got mad about the Women's Health Initiative study that was a high-dose birth control pill style hormone, nothing even similar to the vaginal hormones that we prescribe today. And they got scared and they put that box on. And now 20 years later, they haven't taken it off yet, even though it's not based in any real data. And so we have met with the FDA, and we're actually hoping to meet with them again soon to really work with them to change this box labeling. And so actually, you guys we talk all the time, there's nothing we can do. There's nothing we can do. You can click on that link and that I just put there and actually share your voice with the FDA and say, hey, FDA, this is not fair. The box labeling shouldn't be on there. It goes through all the data. We put together a really lovely spread. It's a nonprofit, and we're trying to get this labeling changed from the FDA because it's just wrong. It's actually lying to women. We published that Medicare could save between $6 and $22 billion a year if women got vaginal estrogen. Less hospitalizations, less UTIs visits, less antibiotic use. And at the meeting I was just at, someone presented data that looked at 11 million women and separated those on vaginal estrogen, those not on vaginal estrogen. And there was a 73% reduction in mortality in those people who took vaginal estrogen. So there's a chance that you are risking 73% mortality, like you're not doing 73% mortality reduction because of a fear of cancer, that there's no data to show that there's any cancer risk. And it's so crazy how fear is killing women. It's killing women. And I just and doctors don't know how to prescribe it. They don't know how to do it because they were never taught. And that's why my advocacy, that's why I have passion coming through my ears, because it's really just education that we need to do. It's not safety, it's not cost, it's an education problem. Will using only vaginal moisturizer help? It will help decrease pain with sex a little bit. So if you have 8 out of 10 pain with sex, it'll bring it down to about 5 out of 10 pain with sex. That's what the research shows. It will help with your comfort. It will help a little bit less pain all around. It may help a little bit with urinary symptoms and wearing pants. It's not going to necessarily help with preventing UTIs. It's never been shown to do that. And so that's where, again, and we love moisturizers and lubricants. I'm not minimizing them. They're fabulous. We love them. But the question is there more? Are there more things that you could safely and comfortably be using? Let's see. I mean, the crossover symptoms of a UTI, how do you tell if you have one? So UTIs are your pain with urination, like deep pain with urination, increased urgency, bladder pain, and it can go, again, fevers, chills, kidney pain, things like that are UTIs. So anytime you have pain, deep pain with urination, you want to get checked out. I have HER2 and won't take tamoxifen because of the uterine cancer risk. So there you go. So that's a choice that you have given, right? You've been suggested to take this thing and you are afraid of, it's a very small, but again, you've looked at the data and you are not, this is called shared decision making. And your doctor should be able to have this kind of discussion with you about what are the risks and what are the benefits. So I think another thing I want to think about is, there is the risk of taking tamoxifen, and then there's the risk of not taking tamoxifen. And we don't know which, that's the real question, is what's the risk of taking it and what's the risk of not taking it? Same with vaginal estrogen. What is the risk of taking it? 2 papers that are poorly done with the wrong doses that show a blip in recurrence only on AIs, not on tamoxifen and not when you're on nothing, versus all the papers that show no risk, versus 73% reduction in mortality from UTIs. And so what is the risk that we're willing to take when we actually look at the data? Lots of papers to show UTI reduction and mortality reduction. Almost no papers, 0 papers that show mortality with vaginal hormones. So so interstitial cystitis is bladder pain, and often bladder pain is from hormone changes. So menopause creates this IC-like picture. So there's a lot of overlap here. Now, there are people who have ulcerations in their bladder, and that's a different condition. But a lot of IC is just hormonal changes from chemotherapy, from menopause, from things like that. I think we answered. And then hyaluronic acid, they asked about, is also a moisturizer. Again, that goes in line with all the moisturizers that I just talked about. If you had IC before cancer, again, you want to see a specialist. We see a lot of about bladder pain issues. And again, similar, it's either a tissue problem from hormones, a muscle problem, or a nerve problem. And those are the things that you want to get checked out because we do have a better understanding of these things than we used to. I think we're at 7 o'clock. I hope this was helpful. Did you guys learn something? I know I got a little ranty there at the end, and I hope it landed okay. Was this helpful? Fabulous. Well, thank you so much for having me. I really, what an honor. And it's truly an honor when people give you their time. There's so much things on the internet. There's so much content. There's so many things pulling at all of our attention. And so for you guys to take the time to be here and to show up for this, to listen to this, it is truly an honor. And really, thank you so much for inviting me here.
Thank you, Dr. Rubin. We really appreciate all your expertise and your willingness to share it with us and your incredible examples. So thank you for joining us tonight.
All right, everyone, have a good night.
Bye, everyone.